Good afternoon, everyone. Thank you for joining us. Stephanie Winters here with the Vermont Medical Society. Just giving folks a moment to hop on since we started the broadcast, and we'll get started in just a moment. Okay, good afternoon, everyone. Thank you for joining us. Stephanie Winters here with the Vermont Medical Society, welcoming everyone to our Refugee Health webinar series. Some of you may know we've been holding these since June, almost every week on different topics. And today we're happy to present the topic of hepatitis B virus infections in the refugee population in Vermont. So I just have a few disclosure slides, and then I'll get to introducing our presenter for today. So this is accredited and approved for CME, for continuing medical education and for social work credit. So here's the disclosure. It's 0.75 category 1 credits. This is our disclosure slide. We do not have any financial disclosures, and Laura doesn't have any financial disclosures either. And then this is our series webpage. So if you go to vtmd.org/refugee-health, you will get to this page. It shows our upcoming events and how to register for them, and also all of the recordings and all of the presentations of the sessions that we've already held, as well as a number of resources that we have put up there for you to look at and be able to put into practice. This webinar series is thanks to a grant and a relationship with the Refugee Health Office in Vermont, as well as Dr. Andrea Green, who's really spearheaded a lot of this work in Vermont. So with that, I will now pass it over to our speaker, and I'm happy to introduce Laura. Laura Catoe is an infectious disease nurse practitioner at the Infectious Disease and Travel Clinic at the University of Vermont Medical Center. So take it away. Thank you so much.
Hi, thank you for having me. So hepatitis B is one of the topics that's very dear to my heart. I see a lot of hepatitis B in our clinic, and it's one of those viruses that's not straightforward. So I hope through this presentation, it will help if you see any Hep B, help you with that. So we're going to go over the epidemiology, the virology, clinical stages, determining the degree of cirrhosis, treatment for the hepatitis B, hepatocellular carcinoma, and then maternal to fetal transmission. So hepatitis B virus, it is transmitted through blood exposure or through sex. It's a more blood exposure though, it's about 5% chance through sex. It's versus hepatitis A, which is a foodborne transmission. So when you think of Hep B, you're thinking of blood exposure, mother, baby, or through sex. Worldwide, about 296 million people worldwide have hepatitis B. And the biggest thing for hepatitis B is dying of liver-related disease, and we will go through that further. Hepatitis B is the leading cause of hepatitis, cirrhosis, and hepatocarcinoma. 30% of cirrhosis and 53% of the liver cancer in the world. Approximately 15 to 40% of patients with chronic Hep B will develop cirrhosis and stage liver failure, or as I said before, hepatocellular carcinoma in their lifetime. Humans are the only known reservoir for hepatitis B. Hope I see a chat message. Sorry, I wasn't sure if that, gotta get that. Here we go. So recently, the World Health Organization published new guidelines on HIV and hepatitis screening for individuals. In it, they now say that we should be basically screening 5 key populations: men who have sex with men, trans and gender, diverse people, sex workers, and people who inject drugs, and people in prisons and other closed settings. And our population, we need to think about that 96% of all hepatitis B infections occur in low and middle income countries. And screening, one of my jobs is I screen the new Americans when they come, the domestic health exam. And most often, this is one of the things that we find the most, is that somebody has an active hepatitis B infection that they did not know about, which would make sense. They're coming from the low and middle income countries. So some of this is, a lot of this is due to the low vaccination rates that we all know of. This data is a little bit outdated. It's the most current data that I could find, but the estimated number of hepatitis B virus infection among children under the age of 5, you can see the areas where it's most prominent, where we do see a lot of new arrivals coming from. So hepatitis B patho. The hepatitis B virus has a complex life cycle. The virus enters the host liver cell and is transported into the nucleus of the liver cell. Once inside the nucleus, the viral DNA is transformed into closed circular DNA, which serves as the template for the viral replication. The hepatitis B virus is then packaged and leaves the liver cell within the stable viral DNA remaining in the nucleus, where it can integrate into the DNA of the cell. And it continues to create hepatitis B. Then we just talk about the Hep B antigen. Here is that cell attachment that occurs. And this is what we will test for when somebody has an active hepatitis B infection. And I will go furthermore with the testing. So Hep B DNA replication, it occurs again at the hepatocyte. Is a major site of viral replication. The DNA goes into the nucleus, forms the circular, covalently closed circular DNA, which makes the mRNA, which serves as a template to produce all of the Hep B antigens and reverse transcriptase. Hepatitis B is not cytopathogenic. There is a high spontaneous error rate, which why hepatitis B can have many mutations. The Hep B genome itself has 4 open reading frames in the genome. The S are the surface codes for Hep B surface antigen. That is the test that is present when somebody has an active hepatitis B infection. Hep B core can also show that they have a past Hep B infection. And again, we will go over that in more detail. Hep B E antigen, this purpose is not clear. It may down-regulate tool-like receptors, show decrease in cytokine response. Mutations can occur in the Hep B E antigen pre-core gene, and this does not interfere with viral replication. You can have be Hep B E antigen positive and be both infectious and pathogenic. This is secreted in the blood, and it serves as a marker for viral replication. We use this to determine how active somebody's hepatitis B infection is. And there are other specialties that do not use these markers. So it is more of a controversial test. So if somebody is exposed to hepatitis B, how long can it take for the hepatitis B antigen to be detected into somebody's blood? On average, it takes about 4 weeks after exposure of the virus. Half of these patients will no longer be infectious by 7 weeks after onset of symptoms, and all patients who do not remain chronically infected with Hep B antigen negative by 15 weeks after onset of symptoms. In our new American population, I have yet to come across somebody who was newly infected with hepatitis B. The majority of individuals either have had the virus in the past or have an active infection at the current time. There are 10 genotypes of hepatitis B. B and C are the most common in Southeast Asia. And hepatitis C genotype is associated with a more severe liver disease and the hepatocarcinoma. In our most recent population who's arrived to the US, there was this, I was looking and seeing what data was actually known about the Afghan population. There was a review article, and not much research has been done that said, looked at how much hepatitis B is in the Afghanistan population. As we know, it's a very least developed country in the world. It has low levels of educational literacy and limited health and social infrastructure, and they've had widespread conflict. And unfortunately, there's not a lot of data on how much hepatitis B is in the population of Afghanistan. We look at other countries such as the Democratic Republic of Congo, and we know that they have much higher rates of hepatitis B. In Afghanistan, we're just not sure what the actual levels of Hep B are. So transmission of hepatitis B. As we've mentioned before, countries of high levels of Hep B, it's about 8% of that population has active hepatitis B. They can be infected either through the time of birth from chronically infected mother or horizontal in early childhood, such as bites, skin lesions, or unsanitary habits. Also can be infected through contaminated needles, contact with blood, saliva, or through sex. Obviously, best to prevent if possible transmission. This is the two different types when we look at childhood infection and adult infection. It's important to note in the childhood infection, 90% develop chronic infection. Of that, you can go down here, 40% develop cirrhosis. 10% of the childhood infection spontaneously clear the virus, and then it would go on, nothing else further. In the adult infection, you can have either acute, which 95% clear the virus, completely different than the childhood infection. Less than 1 develop fulfillment hepatic failure, and then 5% develop chronic infection. This is the population that we are seeing in the New American Clinic, is these chronic infections. Most likely, we don't know, but we're assuming that they got it as a child. Of these, it further gets broken down into chronic hepatitis. Of that, 15 to 20% develop cirrhosis, and we as providers will need to monitor that closely. This is the most tricky thing when a new American comes to the clinic, because they're unaware that they have hepatitis B and they could have had it for about 25, 30 years, we don't know. And we need to determine if they have, what their risk of liver fibrosis is and could they have cirrhosis. And we will go into that in more detail. So acute hepatitis B infection, somebody newly acquired the Hep B infection. The incubation is 1 to 4 months. You normally have a symptomatic infection, such as tiredness, loss of appetite, nausea, right upper quadrant pain, jaundice, yellowing of the skin. If somebody has alcoholic liver disease or fatty liver disease, it could be worse. The liver enzymes are typically very high, 1,000 to 2,000. In acute hepatitis B, symptoms resolve in 1 to 3 months. Not everybody is cured from acute hepatitis B, and some go on to have an active infection or chronic infection. So this is just a diagram of hepatitis B. You have your ALT is spiking, it's going high, and then it will slowly come back and normalize. Here is an acute hepatitis B. This is what the labs would look like. Hep B antigen would be positive. Hep B E antigen would be positive. Hep B core would be positive. and the viral loads are high and liver enzymes are high. You notice the antibody here is negative. They do not have protection of hepatitis B, which is why they got infected. This is immune after infection, so they have now resolved their infection. The antigen goes to be negative. Antibody is now positive. Hep B core is positive. When you see a Hep B core positive, this happens a lot in the new American population. It means that they've had past infection. They do not have virus present, so their Hep B DNA is negative, and their liver enzymes are within normal limits. Immune after vaccine, this is what we hope that we can get to before infection occurs. Negative antigen, they do not have the infection. The antibody is positive, and everything else is negative, including the viral load, because you're immune with it, antibody protection. Unfortunately, this does not happen for everybody, and some people go from acute to chronic hepatitis B infection. And this would be, you would look at your hepatitis B antigen and it would be positive over 6 months. You could also see persistence of elevated liver enzymes. Remember, we talked about in infants, 80 to 90% of infants go from acute to chronic. Young children, it's 10 to 25%, and adults, it's less than 5%. There are multiple phases of chronic hepatitis B when it's broken down. There's this immune tolerance, immune clearance, inactive residual, and reactivation. So this is just a review. Acute hepatitis B, your antigen is positive. Your E antigen is positive. You have viral load. You are not protected against hepatitis B's, and your cores, both IgG and IgM, are miserable. Positive. This can lead to resolved acute hepatitis, where your antigen would be negative, your DNA is negative, you have antibody protection. Or it can lead to chronic hepatitis. Chronic hepatitis is when your antigen remains positive for greater than 6 months. You may or may not have levels of virus. Your E antigen may or may not be positive, and your antibody is negative. Your core here is always positive for AB IgG. And then chronic hepatitis can evolve, and it can go into reactivation into these 4 stages: immune tolerant, immune clearance, inactive residual, and reactivation. Okay, so we're going to go and talk about patients with chronic hepatitis B should be regularly monitored. Hep B DNA and ALT levels vary during the course of infection. Unlike hepatitis C, where the viral level does not matter, hepatitis B, the virus level does matter. You have to follow them. Typically every 6 months we get labs, because patients who are not candidates for treatment at this time may become candidates for treatment in a year or 2. What we do in my clinic is I schedule 6 months in-person follow-ups, and it's a great way to get to know, especially our new American population. And they come, it's great. So typically need for regular follow-up. This is, I would say, the majority of our new American populations who have hepatitis B. They have normal ALT and undetectable HB DNA are considered to be an inactive carrier state. They typically have good prognosis. These patients have had Hep B for quite a long time, could be 20 years, and luckily their liver function has remained stable. They have low levels of virus, and we just hope that it continues to be that way. For these patients, antiretroviral treatment is not indicated. Serial tests are necessary to accurately differentiate them from patients with Hep B antigen negative chronic hepatitis who have fluctuating ALT and or hepatitis DNA levels. Typically, this is not done in the primary care setting. This is a patient who would be referred to us in ID. So we're going to talk about chronic hepatitis B immune tolerant phase. These patients are usually young. Their Hep B antigen is positive. They have high levels of hepatitis B DNA, but they have normal ALT. Their liver enzymes are normal. They have no or minimal disease progression as long as their serum ALT levels remain normal, and therapy is typically not recommended in these patients. With their high levels of Hep B virus, though, it's important that we continue to monitor them and educate them on factors such as not drinking alcohol, having a healthy diet to keep that liver protected. This is what the labs look for the immune tolerant, Hep B antigen positive, Hep B E antigen positive, Hep B E core positive or negative, and the high levels of virus, but their liver enzymes are fine. Then we have the immune clearance phase. So this is defined as elevated hepatitis B levels that hopefully those should be declining as the virus becomes controlled. They have ALT elevation or active inflammation on liver histology. This phase can last for several weeks to several years. In this stage, you see this conversion from the Hep B E antigen to Hep B E antibody. The younger the age of seroconversion from Hep B E antigen to Hep B antibody represents control of viral replication, the better. The onset to complications of increases in patients greater than 40 years of age if you're in the chronic hepatitis B immune clearance phase. Again, here are what the labs look: antigen positive, Hep B E antigen positive. What is different here is the liver enzymes are elevated. And next, we're going to go to the chronic hepatitis B. Chronic hepatitis B, or in the inactive residual phase, they have positive Hep B antigen. They have low or undetectable hepatitis B viral levels and normal liver and ALT enzymes. The liver histology with mild or minimal inflammation and fibrosis. So for these patients, we typically have imaged the liver, and we've determined that they have low or no fibrosis or liver scarring. And then you have individuals who are healthy chronic carriers. Their core is positive, showing that they've had a hepatitis B. They have low levels of virus, and their liver enzymes are within normal limits. Favorable long-term clinical outcomes for these patients, and therapy is not recommended. But at times, you can have reactivation. And this is the important part that we have to monitor in our patients. Reactivation is defined as re-elevation of the Hep B DNA levels. It causes liver inflammation, and this can have 2 to 3% occurrence per year. This is most often occurs in males, genotype C, or that conversion, the Hep B antigen conversion to Hep B antibody after age of 40 years. This usually should be treated to get the elevation of the hepatitis D DNA virus down. So here is a diagram kind of discussing what I just talked about. So immune tolerant, positive levels, very high levels of Hep B DNA, normal liver enzymes, liver histology, normal or mild inflammation, and scant fibrosis. You would not treat these patients. I think of this in our young hepatitis B population that come, like I've seen a patient who's 23, 24, I believe he was, he came over from the Democratic Republic of Congo, was not sure, had high levels of virus, but when I did imaging, his liver was fine, and we just continued to monitor him. Immune active stage, positive or negative, Hep B E antigen. The Hep B viral load is greater than 2,000 copies. Your liver enzymes are elevated. And depending on the liver histology, it would depend if you treat. They are a treatment candidate. And if they had like fibrosis stage 3, we would treat to prevent further fibrosis. And then the inactive stage, you have low levels of virus, normal LFTs, and no inflammation. Treatment is not indicated. Okay, I think we've talked about this quite a bit. Period of reactivation with fluctuating levels of Hep B DNA. Just remember that that can happen at any point. And for hepatitis B, there's a high risk of progression to decompensated cirrhosis and hepatocarcinoma. Hepatitis B can cause hepatocarcinoma even without developing cirrhosis, as it's DNA virus and is integrated into the human genome. So that's important to remember for these hepatitis B patients. So again, going into hepatitis B antigen positive patients or E antigen negative, you're going to treat the patients who have chronic hepatitis B, elevated viral loads, elevated LFTs, and they have demonstration of liver fibrosis. You do not treat the patients who have inactive Hep B, meaning they have negative or low levels of virus and they're showing no signs of fibrosis. What do you do? What do we do for these patients? So again, everybody should be screened in our new American populations for hepatocarcinoma. You can do that by an ultrasound. I try to screen them once a year. It's really helpful when primary cares, if they lose contact with us and they get into primary care, to order that ultrasound or connect them back with us. But you should be checking LFTs at least every 3 months for the year in the initial. And then if LFTs remain normal, you can do it every 6 to 12 months. If LFTs or ALT is greater than 1 to 2 times the upper limit, you need to check the Hep B DNA and exclude other causes of liver disease. You know, could they be drinking heavily as well? Are they drinking? I know in our newest population, people were drinking a lot of energy drinks, like 6 a day, and that was causing spikes in their liver enzymes. So you also can look for signs in the body. Yeah, they could have fever, rash. It's the maculopapular rash that we see, hypertension, renal disease, eosinophilia, abdominal pain, and polyarthritis. So cirrhosis, this is what we don't want to see in our patients. Nobody wants this. Typically, in somebody patient that's had cirrhosis, they have high levels of hepatitis B virus, which has caused inflammation over time on the liver. That inflammation has caused scarring. They could also have alcohol use, drinking, and having any hepatitis B or C increases the damage of cirrhosis or damage to the liver by 50%, or male or older age. Unfortunately, the survival rate for cirrhosis, if it's compensated, 5-year 84%, 10-year survival rate 68%. Decompensated 1 year, it's 55 to 70%, and 5 years, it's 14 to 35%. If you look here, the higher incidence of hepatocellular carcinoma is in these continents here. Again, we see people from these higher risk areas come in on the new American screening. Unfortunately, this is going up. Timely testing happens. It's important that we test people because most people have hepatitis without knowing it. Over 3,000 people die every year. Okay. So how do we assess if someone has advanced liver fibrosis? Sometimes people used to go do liver biopsies. Now that is not the standard of care. You need to assess the degree of liver fibrosis for a couple of reasons. Are they having response to therapy? Or are they at risk for liver failure or the hepatocarcinoma? So liver biopsy is the gold standard, but it's invasive. You have sampling error, not amenable to frequent repeat sampling. So now we can do things like a transient elastography, real-time tissue elastography, Or you can do simple labs, and the simple labs is called the FibroScan, Fibro test, or FIB4. What is the FIB4? This is something that all primary care could do right there at their office. It's looking at the lab values, AST, ALT, platelet count, and age. It's putting it in a calculator, and it's giving you this cutoff. You can just Google FIB4. If the score is less than 1.45, there's a negative predictive value to exclude advanced fibrosis was 90% with a sensitivity of 70%. Greater than 3.25 had a positive predictive value of 65% and a specificity of 97%. If you see a cutoff of 1.45 and higher, you need to order another test of imaging. So patients are categorized into 3 FIB4 index using cutoff values, less than 1.45, 1.45 to 3.25. And these here, we need to do imaging. I normally do a liver elastography test. That gives me my ultrasound and also gives me the advanced fibrosis score to see where the liver is. Greater than 3.25, it's a high predictive value that they have cirrhosis. However, you still do need to do imaging to confirm that diagnosis. You could do an ultrasound, which can show cirrhosis on the ultrasound. Talk about that. So the FIB4 index reduced along the regression of the fibrosis stage, while the FIB4 index increased along the progression of the FIB4 stage. So what is the treatment for hepatitis B? The goal is to suppress hepatitis B viral load, reduce cirrhosis, and reduce the risk of hepatocarcinoma and improve the survival rate. Remember, we've talked about this a lot. Hep B is not straightforward. There's not a to treat or not to treat. You have to consider many things. You have to consider the hepatitis B virus level. Do they have inflammation? What's their antigen status, E antigen test, the age, the evidence of cirrhosis, and clinical picture. You don't want somebody to come on and off hepatitis B medication because that can also cause a reactivation. So when you think about the clinical picture, you need to think is, will they be able to be compliant with that treatment? So this is going over what we've talked about. This is a good diagram that shows somebody's positive. You need to look again at their liver enzymes test. Here, we're going to go over that they have their liver enzyme shows that it is elevated. You're gonna test the viral load is greater than a high viral load. You're gonna treat these patients. If somebody has a less than 20,000 copies of virus and their liver enzymes are normal, those are no treatment. You monitor these patients every 3 to 6 months. If their viral load is greater than 20,000 copies, here you look at their liver enzymes and then decide if you're going to need to get advanced imaging or not. Depending on your advanced imaging would depend if you treat. Treatment of chronic hepatitis B virus infection in resource-constrained settings. So here's another demonstration of hepatitis B in the treatment. We talked about this quite a bit. So really, we're treating an immune active, positive or negative. They have elevated viral loads, and you were going to treat those. What do we treat with? Mainly, we treat with entecavir, tenofovir, or Remlady. And so what we're looking for is we monitor the LFTs, the age, and we want to, I think that we did that one actually, sorry. So HIV and Hep B co-infection, this is treated differently. I won't go too much into that. So maternal and infant transmission, I think we talked about this, may occur in utero at the time of birth. The high protective efficacy, 95% of neonatal vaccination suggests that infection occurs predominantly at or birth. 85 to 90% of infants born in hepatitis B antigen positive mothers, and 32% infants born to Hep B antigen negative mothers. Here in the States, what we try to do if we know somebody is hepatitis B is the child will get immunoglobulin and then started right up on the Hep B's at the time of birth, Hep B vaccines. There is no correlation of the Hep B viral loads with the risk. There's no evidence that C-sections prevent maternal to infant transmission. And it's important to note that breastfeeding does not appear to increase the risk of transmission. I tell this a lot to the new Americans. So here's what hepatitis infants should receive. They should receive the HB-Hib vaccine, and the first dose of vaccine should be given within 12 hours of birth. The second and third dose at 1 and at 6 to 12 months. And this has a protective efficacy rate of 95%. And that's all I have.
Fabulous. Thank you so much, Laura. That was really in-depth information, and I'm really happy that you were able to share that with all of us. If people have questions, please type them in. I did have a question. How do you, with the importance of this this disease and this virus, especially in some of our refugee population, how do you talk to your patients about this and about the protections and sort of that conversation with your patients?
Yeah, I think that's a great question. So we try to simplify it. Definitely don't go in as depth as we just did. I talk a lot about how it's a virus. What the virus does is that it goes in their body and attacks their liver. And that liver can cause inflammation, and it can make your liver angry. And then we talk about protective factors of what they can do to help their liver. And then typically we talk about, vaccination status of their partners. If they're married, I ask, do they know if their partner's married, vaccinated? And if we have sometimes we have these, younger men coming over who are infected. And I talk a lot about the risk of, you may not be affected by hepatitis B, but if you give it to somebody else, it could cause them liver damage. So you need to make sure people are vaccinated before you have sex with them. You can have sex, but we have to be safe about it.
That's great. That's great. That's good information, really, to share with people. So it's fabulous. I don't see any questions. I think that was a lot of information, and I think people were, got a lot of information in your presentation, and so they are pretty quiet, don't have questions, but certainly I think if you're amenable, if people do have questions after the fact, I can send them on to you, and we can get those answered. So thank you so much. Thank you for putting together that and sharing that information, and we really appreciate that.
Thanks. Have a great day.
All right. Thank you, everyone. Thank you for joining us.